All right. So today we are going to discuss about one of the most important disorder of endocrine system, that is diabetes mellitus. Apart from this disorder affect a great, we can say, chunk of the population or great number of individuals all over the world, and generally covers the group of disorders which affect the reuptake of the glucose by the body cells. It is also known as mother of all diseases. All right, so we also know that it is generally divided into type 1 diabetes mellitus, present over here, and type 2, present in this box. So let's begin with type 1 diabetes mellitus. It is said that it occurs due to autoimmune disorder or is under the autoimmune disorder category, and occurs due to human enterovirus, as this virus enters into the body from air pollution, from water or food we intake, vice versa. It affects and comes in contact with T cells. T cells produce cytokines. Cytokines further stimulate plasma cells, which make antibodies. These kind of antibodies are also prepared during these conditions, such as rheumatoid arthritis, systemic lupus erythematosus, and vitiligo also produce these kind of antibodies. Okay, before we go deep into the discussion, I would also like to tell you people that this type 1 generally affect the age group less than 30 years and affect the 10% world population at a given time, and is also known as insulin dependent diabetes mellitus. Let's begin with simple anatomical discussion and physiological discussion. We know that pancreas is having, that is, beta cells, and in each beta cell, as I had already told in my insulin hormone video and pancreas video, that glucose can enter directly into the beta cell. As the glucose enter into the beta cell, it makes ATP under the Krebs cycle, and as the number of ATP increases in the beta cell, it closes down or switch off potassium channels. Potassium start to accumulate in the, we can say, cell and make it more electropositive. This opens the calcium channels, and during this time our beta cell had already made insulin, which is present in the vesicles. This calcium is going to, we can say, cause exocytosis of this insulin, and insulin comes into the, we can say, general circulation. All clear? All done? Okay. So now these antibodies attack, first of all, anti-IELTS antibodies, anti-IELTS of Langerhans antibodies, which generally attack the beta cell, leading to poor production or no production of insulin. Also, we can say that antibodies also attack the vesicles, these vesicles, therefore known as anti-insulin antibodies. Ultimately, there is decreased or poor production of insulin. What was insulin doing under the normal physiological action? Under the normal physiological circumstances, insulin binds on the insulin receptors, which are also known as TKR receptors, tyrosine kinase receptors, and cause intracellular signal, which makes more glucose channels or glucose transporters, and the glucose present outside the cell membrane enters into the cell. For example, when we are eating, our glucose level, which is this amount, that is 8120 mg per dl, under the normal circumstances, normal range, it start to increase, and insulin is secreted to bring down, or we can say maintain, the blood glucose level. It is known that insulin melts glucose. All right, so now there is no insulin. Will there be any insulin receptor activation? No. Can glucose enter into the cell? No. So blood glucose level will rise. So this is all about type 1 diabetes mellitus. Okay. So what comes under the type 2 diabetes mellitus? It is, first of all, affect 90% of diabetic patients above the age of 30 years, and is also known as non-insulin dependent diabetes mellitus. Non-insulin. So it means that insulin is there, but why then it is not acting on the body cells? This is the question. So now I am going to answer that question, that due to metabolic syndrome, which include fasting blood glucose sugar level more than 100 mg per dl. So what is the normal? Under the normal, the FBS, fasting blood glucose sugar level, should be less than 100 mg per dl. If it is going up to 125, it is known as pre-diabetic. Condition. Okay. So if it is going to 126 for more than 2 times, 3 times, the report is positive, then the patient is known as diabetic. Okay. Then in the terms of triglycerides, 150 mg per dl or more than that, HDL 50 mg for females, and for males it is 40 mg per dl. And when we talk about BP, consistent BP for more than 130/80 mm mercury, and if the first degree relatives are having diabetes, there are many chances that diabetes type 2 can occur. So when we talk about ethnicity, Hispanics, yes, please note it down. Hispanics plus Asians are 14% affected, whereas Japanese people are less affected. Okay. So this also is due to obesity. Like me, I am obese, lack of exercise, stress, cortisol, increased cortisol level, and decreased vitamin K. If the female patient is having PCOD, polycystic ovarian disease, type 2 diabetes mellitus can occur. So all these associated factors or activities causes one single word, that is insulin resistance. So what is insulin resistance? The receptors present on the cells show resistance, that we are not going to take you, buddy. We are not going to bind with you. We are not going to send intracellular signal. So can glucose enter into the body cells? No, as there is no insulin binding over here. So insulin will start increasing. in the blood or in the extracellular fluid, leading to hyperinsulinemia will occur. Okay. So now our beta cells think that we should increase the insulin production in order to meet the demand. We think that the cells will accept if there is more insulin. So beta cells start making more and more insulin. But there is no binding over there. So ultimately beta cells feel exhausted. Oh my God, this is again going to affect the condition of the patient, and there will be poor insulin production due to beta cell damage. So once again glucose level will shoot up, spike, show spike and cause hyperglycemia. So in both the conditions, whatever the causes may be, hyperglycemia is there. All right. Also, beta cells, I had taught you in the anatomy and physio lectures that beta cells also make amylin and C-peptide. Amylin makes amyloid proteins which further damage the beta cell. All right. So whatever may be the causes or pathophysiology, the main thing is that there is hyperglycemia. So now I will discuss the sign and symptoms in relation to the I will say diabetes. Okay, so first of all, let's take our kidneys. In kidneys, we know that there are 1 million nephrons, and in each nephron there is a Bowman capsule and proximal convoluted tubule. Bowman capsule, proximal convoluted tubule. In the Bowman capsule, afferent arteriole and efferent arteriole come and exit, bringing down what? Hyperglycemic or hyperosmolar blood. So this blood is exclusively rich in glucose. So glucose start shifting into Bowman capsule. And we know that 99.9% or 100%, near about 100%, glucose is reuptaken by the proximal convoluted tubule. And the amount of the glucose in the urine is nil. Okay, but what is happening over here? All the pumps present on the proximal convoluted tubule get busy while taking glucose. So extra glucose comes into the urine. This is known as glycosuria. Okay, so let's assume another condition, that we are having a beaker, and in this beaker semi-permeable membrane is there, and there is a fluid on this part, there is a fluid on this part. This fluid is having 100 parts of I will say glucose, and this fluid is having 10 parts. 10 we can say molecules of glucose. This is 100 molecules of glucose. So the osmotic pressure on this side is more. Osmotic pressure, as we know, the pressure exerted by the fluid on the virtue of the solute present in it. So the fluid will start shifting over here. What I am going to tell you or teach you, that when glucose shift from the Bowman capsule to the end part of the distal part of the nephron, it takes water with it. So increased glucose excretion plus water excretion leading to, my dear students, polyuria. Okay, all right, well done, good. So the problems are not going to end for the patient here only. So glucose is present in the blood, hyperglycemia blood is there, hyperosmolar blood is there, okay, and the glucose is not entering into the cells, but cells need energy. For their survival. So cells or the body start to make ATP from the new sources, which is known as gluconeogenesis in the liver. But from where this glucose is going to come? It is going to come by the entry of superhero, that is glucagon. Glucagon will stimulate lipolysis, that is breakdown of these green color fat cells, adipocytes, into free fatty acids. Fatty acids will be converted into ATP. Okay, one point. And also glucagon will cause proteolysis or protein lysis, making amino acids from the muscles. The glucagon will shift out amino acids which will make ATP in the liver. Okay, this is a good mechanism for the time being, but it has its own cost. What is the cost of this process? it is going to cost the patient very much. For example, I will say that it will cause breakdown of fat, lipolysis, will cause weight loss. For example, there is a fat over here in my tummy, in my abdomen. If I am losing this fat, which I supposed to be one day, then there will be weight loss, obvious. And when there is weight loss, the body needs calories. It causes polyphagia. That is why I always insist my students not to cram up, not to do rote learning, this and that. Always believe in making connection between the concept, points, what I am studying, what I am learning, how this is going to, we can say, affect this part of the medical surgical nursing and that part of medical surgical nursing. Only then you will be able to clear the NCLEX RN exam and government job exam, AIMS PGI exam. Okay, so our friend glucagon is making time being adjustments for us, but during that time, what is going on in other parts of the body? This is important, my dear students, as glucose is already shoot up and is in the spike. So this glucose rich blood when reaches this glucose blood when reaches, I will say, first here in the brain, in the hypothalamus, there are osmoreceptors. There are osmoreceptors in the hypothalamic activity and the area. So this will sense glucose level and initiate a process known as polydipsia or increased thrust mechanism. So far I had taught you triple P: polyphagia, polyuria and polydipsia, whatever the sequence. But now you know that how these things happen in the body of the patient. Okay, so now this hyperglycemic blood and its problems are not going to end over here. So this blood when reaches into the I will say hyperglycemic blood reaches into the blood vessels. So in the blood vessels, what this naughty or notorious glucose is going to do is making plaque formation. Glucose plus lipids make plaque, which is known as atherosclerosis, plaque formation. And diameter of the micro blood vessels will obviously decrease, leading to poor passing of the blood to the organ. For example, a organ is present over here, it will be receiving less blood supply and less gas exchange. Less blood supply, less oxygen, less nutrients, less CO2 exit out. Okay. Another part is that the glucose binds with proteins to make the basement membrane of the blood vessels rigid. Leading to arteriosclerosis, hardening of the blood vessel, arteriosclerosis. Okay, for example, I am having myocardium layer of the heart over here and it is receiving blood from the coronary artery. Okay, and its branches. So one branch over here develops arteriosclerosis or atherosclerosis due to hyperglycemia. This area of the heart is going to receive less blood supply, leading to myocardial infarction. Clear? Done. First side effect, or we can say symptom. Then this condition will also develop in the legs. For example, our legs are having blood vessels here and clot formation occur here. Distal part is not going to get proper blood supply. So peripheral arterial disease, peripheral artery disease can occur. So this part can also occur in the brain. Atherosclerosis and arteriosclerosis, leading to stroke, which can be of ischemic type. Ischemic stroke. Okay, clear? All right, now I will tell you how this notorious glucose is going to, I will say, hardcore criminal of our body when it is in the increased amount is going to affect the retina. So our eyeball is having this part, then is cornea, over here present lens, and in the later part is present on the other side is retina. So this retina is having retinal artery. So if retinal artery is going to or going to show the atherosclerosis, arteriosclerosis, this retinopathy will occur, which will obviously affect blood vision, cause blood vision or vision problems. All right. Then what is, I will associate cataract here also, that in our body cells there is a system which convert glucose into sorbitol, with the help of many enzymes such as sorbitol, please note this word, sorbitol hydrogenase enzyme convert sorbitol into fructose. But some cells of the body don't have sorbitol dehydrogenase, and one part is lens is not having sorbitol hydrogenase. So sorbitol will accumulate over here and pulling more and more water, making it like cataract like situation. Blood vision loss can be there. All right. So when we talk about nephropathy, in the nephropathy, these plaque formation in the afferent and efferent arterioles will start forming, leading to formation of some nodule like structure known as Wilson nodule. All right. And also damage will occur over here in the, we can say, nephron membrane, and large size albumin proteins will come out in the urine. Albumin proteins will start excreting out of the body via urine, causing albuminuria. So what is the normal range of albumin in the body? It is 3.4 to 5.4 grams per dl. So this is going to decrease. Cataract I had taught you, retinopathy, stroke. Now comes the demyelination, and this demyelination will greatly affect many parts of the body. For example, our neurons are having myelin sheath on them, and once again these myelin sheath contain Schwann cells. Schwann cells don't have sorbitol hydrogenase, and it will accumulate, yes please, sorbitol. Therefore demyelination will start. The myelin sheath of the neurons will start getting broken down, leading to poor impulse transmission. So for example, in the legs we have arteries or veins in the legs. For example, there is a vein in the leg, and the walls of the veins are controlled by nervous system. Okay, so the blood will not able to go upwards and start pooling in the lower limbs or the foot area. All right. So moreover, the nerves are getting damaged due to this condition, demyelination. So it will create sensory loss or numbness. Okay, blood pooling is there. Okay, and whenever there is hyperglycemia, the immune system show very decreased activity. Okay, and there is lack of, we can say, nerve endings, sensory input. Okay, so whenever there is a very micro injury in the foot, occurs, there is decreased immune system response, increased blood pooling, and increased glucose level. So the microorganisms are going to have a big party over there. So even a small injury can prove very harmful in the terms of and leading to diabetic foot ulcer, diabetic foot problems, etc. And and can also lead to amputation. Very, very big serious problem which is commonly present in the diabetic foot. So I had taught you so many points in a very brief that is time. Kindly make notes, kindly make attention, kindly highlight the important points. And also the problems are not ending. The urinary bladder is having nerve endings. These nerves are already weak, so urinary retention can be there. Urinary retention can be there. GI system is also controlled by nervous system, so decreased GI motility will be there. Decreased GI motility will be there. And orthostasis, the accumulation of blood, pooling of blood in the lower limbs. Burning and tingling sensation in the foot, paraesthesias can be there. Paraesthesias can be there. So we had covered a lot in this video regarding diabetes, type 1, type 2 diabetes and its pathophysiology, along with association with the sign and symptoms. I am going to make a separate video on the insulin therapy and the drugs associated with the diabetes. But here I had already told you about the diabetes. Some points are left over here, such as oral glucose tolerance test. So when we administer glucose to the patient, for example, when the nursing staff or the medical staff administers 75 gram of glucose, insulin is present over there? No. So the same amount will remain over there in the blood even after 30 minutes, 1 hour and 2 hours. 100 grams glucose was given and this value was again assessed or tested after 1 hour, 2 hour and 3 hour. Same amount of glucose is present, which comes under what? It comes under oral glucose tolerance test, OGTT. Okay. And last one is HbA1c, which means that the RBC are having for example, these are the RBC which contain hemoglobin, and glucose binds with this hemoglobin, making glycated hemoglobin. So the age of the RBC is 120 days, and this test is done, HbA1c test is done to check the chronic diabetes mellitus or chronic assessment of diabetes, because after 120 days still glucose is binding with the hemoglobin. Okay, so thank you very much for watching this video. Kindly subscribe and share this video with all your medical fraternity, MBBS, pharmacology, BDS students in order to understand about the diabetes mellitus. Thank you very much for watching this video.